Sympathetic component of the autonomic nervous system. Autonomic nervous system. The autonomic nervous system comprises sympathetic and parasympathetic components. Sympathetic is active during flight or fight. During any of these activities, the pupils dilate, skin gets pale, blood pressure rises, blood vessels of skeletal muscles, heart, and brain dilate. There is hardly any activity in the digestive tracts due to which the individual does not feel hungry. The person is tense and gets tired soon. Fig. A 2.1, parasympathetic has the opposite effects of sympathetic. This component is sympathetic to the digestive tract. In its activity, digestion and metabolism of foods occur. Heartbeats. Normal person is relaxed and can do creative work. Autonomic nervous system is controlled by brainstem and cerebral hemispheres. These include reticular formation of brainstem, thalamic and hypothalamic nuclei, limbic lobe, and prefrontal cortex, including the ascending and descending tracts interconnecting these regions. Sympathetic nervous system. Sympathetic nervous system is the larger of the two components of autonomic nervous system. It consists of two ganglionated trunks, their branches, prevertebral ganglia, plexuses. It supplies all the viscera of thorax, abdomen, and pelvis, including the blood vessels of head and neck, brain, limbs, skin, and the sweat glands, as well as erector pylorem muscle of skin of the whole body. The preganglionic fibers are the axons of neurons situated in the lateral horns of T1L2 segments of spinal cord. They leave spinal cord through their respective ventral roots, to pass in their nerve trunks, and beginning of ventral rami via white ramus commune icons, WRC. There are 14 WRC on each side. These fibers can have following alternative routes. 1. They relay in the ganglion of the sympathetic trunks. Postganglionic fibers pass via the gray commune icons and get distributed to the blood vessels of muscles, skin, sweat glands, and to erector pili muscles. Fig. A 2.3, 2. These may pass through the corresponding ganglion and ascend to a ganglion higher before terminating in the above manner. These may pass through the corresponding ganglion and descend to a ganglion lower and then terminate in the above manner. 1. These may synapse in the corresponding ganglia and pass medially to the viscera like heart, lungs, esophagus. 2. These white rami commune icons, WRC, pass to corresponding ganglia and emerge from these as WRC, unrelayed, in the form of splanchnic nerves to supply abdominal and pelvic viscera after synapsing in the ganglia situated in the abdominal cavity. Some fibers of splanchnic nerves pass express to adrenal medulla. Sympathetic trunk on either side of the body extends from cervical region to the coccygeal region, where both trunks fuse to form a single ganglion impar. It has cervical, thoracic, lumbar, sacral, and coccygeal parts. Thoracic port of sympathetic trunk. There are usually 11 ganglia on the sympathetic trunk of thoracic part. The first ganglion lies on neck of ist rib and is usually fused with inferior cervical ganglion and forms sphilae ganglion. The lower ones lie on the heads of the ribs. The sympathetic trunk continues with its abdominal part by passing behind the medial arcuate ligament. The ganglia are connected with the respective spinal nerves via the white ramus commune icons, from the spinal nerve to the ganglion, and the gray ramus commune icons, from the ganglion to the spinal nerve, i.e. ganglion gives gray branches. 1. Gray rami commune icons to all the spinal nerves, i.e. T1 T12. The postganglionic fibers pass along the spinal nerves to supply cutaneous blood vessels, sweat glands, and erector pili muscles. 2. Some white rami commune icons from T1 T5 ganglia travel up to the cervical part of sympathetic trunk to relay in the 3 cervical ganglia. Fibres from the lower thoracic ganglia T10L2 pass down as preganglionic fibers to relay in the lumbar or sacral ganglia. 3. The first 5 thoracic ganglia give postganglionic fibers to heart, lung, aorta, and esophagus. 3 lower 8 ganglia give fibers which are preganglionic, unrelayed, for the supply of abdominal viscera. These are called splanchnic, visceral, nerves. Ganglia 5-9 give fibers which constitute greater splanchnic nerve, splanchnic nerve. Some fibers reach adrenal medulla. Ganglia 9-10 give fibers that constitute lesser splanchnic nerve. Ganglion 11 gives fibers that constitute lowest splanchnic nerve. Nerve supply of heart. Preganglionic sympathetic neurons are located in lateral horns T1-T5 segments of spinal cord. These fibers pass along the respective ventral roots of thoracic nerves, to synapse with the respective ganglia of the sympathetic trunk. After relay, the postganglionic fibers form thoracic branches which intermingle with the vagal fibers, to form cardiac plexus. Some fibers from T1-T5 segments of spinal cord reach their respective ganglia. These fibers then travel up to the cervical part of the sympathetic chain and relay in superior, middle, and inferior cervical ganglia. After relay, the postganglionic fibers form the three cervical cardiac nerves. Preganglionic parasympathetic neurons for the supply of heart are situated in the dorsal nucleus of vagus nerve. Sympathetic activity increases the heart rate. Larger branches of coronary are mainly supplied by bronchial tubes or bronchodilator. The pressure of inspired air also causes bronchodilation. Typical intercostal nerves are any of the nerves belonging to 3rd to 6th intercostal spaces. Beginning. Typical thoracic spinal nerve after it has given off dorsal primary ramus or dorsal ramus is called the intercostal nerve. It runs in the intercostal space, i.e. between the lower border of rib above and upper border of rib below. Course. Typical intercostal nerve enters the posterior part of intercostal space by passing behind the posterior intercostal vessels. So the intercostal nerve lies lowest in the neurovascular bundle. The order from above downwards is vein, artery, and nerve, vein. At first the bundle runs between posterior intercostal membrane and subcostalus, then between inner intercostal and innermost intercostal, and lastly between inner intercostal and sternocostalus muscles. At the anterior end of intercostal space, the intercostal nerve passes in front of internal thoracic vessels, pierces internal intercostal muscle and anterior intercostal membrane to continue as anterior cutaneous branch, which ends by dividing into medial and lateral cutaneous branches. Branches. 1. Communicating branches to the sympathetic ganglion close to the beginning of ventral ramus. The anterior or ventral ramus containing sympathetic fibers from lateral horn of spinal cord gives off a white ramus communicans to the sympathetic ganglion. These fibers get relayed in the ganglion. Some of these relayed fibers pass via gray mans communicans to ventral ramus. Few pass backwards in the dorsal ramus and rest pass through the ventral ramus. These sympathetic fibers are pseudomotor, pilomotor and vasomotor to the skin and vasodilator to the skeletal vessels. 2. Before the angle, nerve gives a collateral branch that runs along the upper border of lower rib. This branch supplies intercostal muscles, costal pleura, and periosteum of the rib. 3. Lateral cutaneous branch arises along the mid-axillary line. It divides into anterior and posterior branches. 4. The nerve keeps giving muscular, periosteal, and branches to the costal pleura during its course. 5. Anterior cutaneous branch is the terminal branch of the nerve. It divides into anterior and posterior branches. Atypical intercostal nerves. The thoracic spinal nerves and their branches which do not follow absolutely thoracic course are designated as atypical intercostal nerves. Thus first and second intercostal nerves are atypical as these two nerves partly supply the upper limb. The first thoracic nerve entirely joins the brachial plexus as its last rami or root. It gives no contribution to the first intercostal space. That is why the nerve supply of skin of first intercostal space is from the supraclavicular nerves, C3, C4. The second thoracic or second intercostal nerve runs in the second intercostal space. But its lateral cutaneous branch as intercostobrachial nerve is rather big and it supplies skin of the axilla as well. 3rd to 6th intercostal nerves are typical. Also 7th, 8th, 9th, 10th, 11th intercostal nerves are atypical, as these course partly through thoracic wall and partly through anterolateral abdominal wall. Lastly, the 12th thoracic is known as subcostal nerve. It also passes through the anterolateral abdominal muscles. These nerves supply parietal peritoneum, muscles of the anterolateral abdominal wall and overlying skin. Site of pericardial tapping. Removal of pericardial fluid is done in left fourth or fifth intercostal spaces just to the left of the sternum as pleura deviates, exposing the pericardium against the medial part of left fourth and fifth intercostal spaces. Care should be taken to avoid injury to internal thoracic artery lying at a distance of 1 cm from the lateral border of sternum. Needle can also be passed upwards and posteriorly from the left xiphocostal angle to reach the pericardial cavity. See Fig 18.6. Foreign bodies in trachea. Foreign bodies like pins, coins entering the trachea pass into right bronchus wider, shorter, more vertical and is in line with trachea, so the foreign bodies in the trachea travel down into right bronchus and then into posterior basal segments of the lower lobe of the lung. Site of bone marrow puncture. The Manubrium sterni is the favored site for bone marrow puncture in adults. Manubrium is subcutaneous and easily approachable. See Fig 13.14. Bone marrow studies are done for various hematological disorders. Another site is the iliac crest, which is the preferred site in children. Posture of a patient suffer from respiratory difficulty. Such a patient finds comfort while sitting, as diaphragm is lowest in this position. In lying position, the diaphragm is highest and patient is very uncomfortable. In standing position, the diaphragm level is midway, but the patient is too sick to stand. Patient also fixes the arms by holding the arms of a chair, so that serratus anterior and pectoralis major can move the ribs and help in respiration. Paracentesis of lung or pleural tapping. Aspiration of any fluid from the pleural cavity is called paracentesis thoracis. It is usually done in the 8th intercostal space in mid-axillary line. The needle is passed through lower part of space to avoid injury to the principal neurovascular bundle. Some clinical conditions associated with the pleura are as follows. Pleuris, this is inflammation of the pleura. It may be dry, but often it is accompanied by collection of fluid in the pleural cavity. The condition is called the pleural effusion. Pneumothorax, presence of air in the pleural cavity. Hemothorax, presence of blood in the pleural cavity. Hydropneumothorax, presence of both fluid and air in the pleural cavity. Empyema, presence of pus in the pleural cavity. Coronary artery, thrombosis of a coronary artery is a common cause of sudden death in persons past middle age. This is due to myocardial infarction and ventricular fibrillation. Incomplete obstruction, usually due to spasm of the coronary artery, causes angina pectoris, which is associated with agonizing pain in the precordial region and down the medial side of the left arm and forearm. Coronary angiography determines the site, of narrowing or occlusion of the coronary arteries or their branches. Angioplasty helps in removal of small blockage. It is done using small stent or small inflated balloon. If there are large segments or multiple sites of blockage, coronary bypass is done using either great saphenous vein or internal thoracic artery as graft. Cardiac pain is an ischemic pain caused by incomplete obstruction of a coronary artery. Discern usually have low amount of sensory output, whereas skin is an area of high amount of sensory output. Sopoia arising from low sensory output area is projected coming from high sensory output area. Axons of pain fibers conveyed by the sensory sympathetic cardiac nerves reach thoracic 1 to thoracic 5 segments of spinal cord, mostly through the dorsal root ganglia of the left side. Since these dorsal root ganglia also receive sensory impulses from the medial side of arm, forearm and upper part of front of chest, the pain gets referred to these areas as depicted in Fig 18.26. Though the pain is usually referred to the left side, it may even be referred to right arm, jaw, epigastrium, or back. Esophageal varices. In portal hypertension, the communications between the portal and systemic veins draining the lower end of the esophagus dilate. These dilatations are called esophageal varices. Rupture of these varices can cause serious hematemesis or vomiting of blood. The esophageal varices can be visualized radiographically by barium swallow. They produce worm-like shadows. Barium swallow, left atrial enlargement as in mitral stenosis, can also be visualized by barium swallow. The enlarged atrium causes a shallow depression on the front of the esophagus. Barium swallow also helps in the diagnosis of esophageal strictures, carcinoma, and achalasia. Coarctation of the aorta. Coarctation of the aorta is a localized narrowing of the aorta opposite to or just beyond the attachment of the ductus arteriosus. An extensive collateral circulation develops between the branches of the subclavian arteries and those of the descending aorta. These include the anastomoses between the anterior and posterior intercostal arteries. These arteries enlarge greatly and produce a characteristic notching on the ribs. Aortic aneurysm. Aortic aneurysm is a localized dilatation of the aorta which may press upon the surrounding structures and cause the mediastinal syndrome.